David Landsberg, who's the Medical Director of the Kidney Transplant Program at BC Transplant, as well as the Renal Program Director at St. Paul's Hospital in Vancouver. A leader in St. Paul's Kidney Transplant Program since it began and a key reason for its success, Dr. Landsberg recently received the Canadian Society of Transplantation Clinical Achievement Award. Dr. Landsberg will speak to us about the current state of kidney transplantation in BC. Dr. Landsberg.
Thank you very much, Anne. It's a great pleasure to be here and seeing so many of friends, colleagues, patients, success stories. It's great to be able to speak to everybody today. I'm sort of trying to just, for the jury, I'm trying to set the stage, and my pitch is pretty simple. And the pitch is that kidney transplant is the best treatment for people with chronic kidney disease, and that the success of transplant is totally tied to the number of kidney donors that we have. And so kidney donation saves lives and enhances lives and actually saves us money as well. So everything that we can do to promote organ donation is I think, hits on so many levels, gives a benefit at so many different levels that it's really something I think we can all totally put our weight behind. So here's just a little bit of what I just said in more detail. So why kidney transplant over dialysis? Kidney transplant increases your life expectancy. It increases the quality of the life, and as well, it saves everybody money. So it really is a no-brainer. So if you just look at some of the statistics, statistics for dialysis patients are less than optimal, and you look at survival curves, and you can see that on the top, the green line, is that patients who have had transplants just live longer than patients who have been on dialysis. And as well, they take a little bit risk at the front end. And so this slide looks at when is your risk higher than dialysis, when are you at equal risk, and then when are you at lower risk. And you can see by about 100 days, the risk with transplant goes below the risk of dialysis, and most importantly, it stays there. So for the rest of people's lives, they're doing a lot better with a transplant than they are with dialysis. And this won't show up very well. Maybe there's some red circles there, but basically, even the people who don't necessarily do very well on dialysis, which are people with diabetes as the cause of their kidney failure, and right now up to 50% of the people who are starting on dialysis have diabetes as the cause for their kidney disease, those people live very much longer with a transplant than they do on dialysis. So it's the best treatment for most people. Age on its own is not necessarily a barrier. So in the Canadian consensus guidelines, which I took part in producing, we say that age is not on its own isn't a barrier to transplant, it's your overall health. Now it's true that as people age, there's a burden of aging that comes with this. They develop other complications, other problems such as heart disease, circulation disease, and maybe they are transplant candidates. But for those who are in excellent health still, other than their failing kidneys, still a transplant is their best option. And this shows you, in fact, that even patients over the age of 70 can do better with a transplant than they do with dialysis. And again, that slide shows that at about 125 days, you break even. And then after that, patients with transplant do better than patients who are on dialysis. And one of the reasons why is that patients on dialysis have a high rate of heart attack, whereas patients with transplant down there in the orange have a much lower rate of heart disease. So transplant is better for them. It's less severe on people's hearts, and people with transplants, have much better health outcomes. And there's a significant cost savings. So most people would say that a transplant costs transplant maybe costs about the same as dialysis in the first year, but after the first year, when the first year you break even, but after that, it's only the cost of the medications and a little bit of follow-up, whereas the cost of dialysis go on and on and on. So over a 5-year period, a transplant saves at least $250,000. And so these are our transplant results. And I just put up all of the organs there for you to see. The best results are up there in pink. This is how long patients live, and you can see their best results are with living donor transplants, but shortly thereafter is deceased donor transplant, and then all the organs go below it. Now that's not entirely fair, because if a transplant fails, a patient can go back onto dialysis, but if a heart transplant fails or a liver transplant fails, there's no substitute for that. So when organ failure occurs with other organs, usually it results in death, whereas at least with kidneys, they can go back onto dialysis. But you can also see that the actual life of the organ with kidney transplants is outstanding, and the pink and then the blue curves are kidney transplants, living donor transplants, which are the best outcomes, than deceased donor transplants. And so this is just a little bit of where we've been, and showing you that we're improving. So 20 years ago, outcomes for transplants were not nearly as good as they are today. So down there at the bottom in the purple, you can see our outcomes about 20 years ago. But over the past 15 or so more years, with better anti-rejection drugs, our results have improved a lot. And it's pretty hard to do much better than, you can see at the very top, at the end of the first year, we're about 97%. So it's pretty hard to do much better than 97%. And so that was for living donor, and you can see the equally very impressive results for deceased donor transplant. So outcomes are good, outcomes have improved, and patients with transplant are living better lives, they're living longer lives, and they're living less costly lives. Your best chance with the transplant is with the first transplant. And so although we do second and sometimes third transplants, you can see that the second time around or more, that the success rate isn't as good. And so one of the determinants of success is the quality of the donor kidneys. So as we get more donors and as we get better quality kidneys, we're going to have an impact on making those first transplants last longer, which is really in everybody's best interest. So these are our results, as people get older, but even for the very much older population, results are pretty reasonable when you compare those results to the results for people on dialysis. And I think I'll just slip over this slide, but basically on the bottom is when we use older donors and we transplant those into older recipients, the outcomes aren't quite as good as they are if we were to transplant them with a younger donor's kidney. But in fact, when you see most of the reasons that curve goes down, 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 is people pass away. But they pass away when their kidneys are working. So a good use of our older donor kidneys is actually to preferentially transplant those into people who are older. The expectation being that kidney will last somebody the rest of their life. When they come to the end of their life, they'll die with that kidney in place, whereas if you give that kidney to a younger person, it's likely that kidney will wear out and the patient will need another transplant. So young kidneys into younger recipients, older kidneys into older recipients probably makes the best use of our scarce resource. So today's focus is on deceased donation. It's getting more deceased donors, but I also want to give a plug for living donation. And one of the great successes in this country has been the Canadian Paired Donation Program, where we enter incompatible pairs. So somebody in my family needs a kidney. I'm willing to do that for them, but unfortunately we're not compatible. So before I would say, I'm sorry, we can't do that, but within the Canadian Paired Donation Program, the pair enters into a registry, and we try to find other pairs in whom there's a donor who matches with the person who couldn't get matched from their donor, and consequently, their recipient gets a kidney from somebody else. And there's lots of different ways to do this, but the most success has been the one that you see over there on your left. And on that slide, it shows these chains where there's a domino where one person donates to a recipient, their donor then donates to another recipient, their donor to another recipient. And the key to this is the one in red. So that's the non-directed donor. So this is somebody who, out of the goodness of their heart, altruistically is willing to donate a kidney to anybody. That person then does not have a recipient tied to them, so they can be a key to unlocking that chain. And then at the end of the chain, there's a donor who doesn't have anybody to donate to. They donate to the waiting list. And we've been able to generate 233 transplants up until the end of 2014, and now probably about 260 or 270 from these living altruistic these non-directed anonymous donors. You can see in BC we've done extremely well in that of all those pairs we've entered, 59% of our pairs have now received transplants, and we've done the most kidney transplants of any program. Number E beside us is in Ontario, so even with a much bigger population in BC, we've actually done the most. And the success has been driven by these non-directed organ donors. So if we have more non-directed donors, we can open up more chains. And so the gift of donation not only is something that's important for us to think about what would we want to happen when we pass on, but what can we do today? What can we do in our lives today that's going to make a difference for somebody? And then just another comment about another impact. People that we're trying to help are people who are very hard to match. So people who are very hard to match, you'll see people maybe in the audience who they say, I've been on the waiting list for 12 or 14 years. Well, the reason they're on the waiting list for 12 or 14 years is because it's very, very difficult to find a compatible donor for them. Up until very recently, we were very siloed. Each province had their own waiting list, and when there was a kidney available, when there was a donor, it was allocated to the two patients in the province who were either the best match or felt to be the best ones to receive that kidney. But with this national program, we're now shipping kidneys across the country. So if you're hard to match, you're registered in this database, and the database will then, all of the donors in the country are now registered. And so if there's a patient in BC who has a donor in Ontario who they match with, that kidney from Ontario will now get sent. And we've been very fortunate for these people who up until now made up about 20% of the waiting list, maybe even 30% of the waiting list, but we're only getting 1% of the kidneys. 1% of the kidneys versus 20 or 30% of the waiting list. We've now already this is the makeup of these people, but we've already in BC done 10 of those transplants since we got started in this program, which is under a year ago. In the past, we would have transplanted 1 or 2 of those people. So again, the more donors, the more possibilities that people have to be compatible, and therefore the amount of help that you can do for people who are really in pretty desperate shape. So my message is that organ donation has a great impact, and anything we can do to improve organ donation is a great thing. So I think I'll stop there. And not to say that we're doing badly in BC, but we can certainly do better. The next speaker will tell you where we're at right now.